So here you are watching coblation tonsillectomy in an 11-year-old child with obstructive symptoms. However, since the tonsil is very large and the child is already 11, I am performing an extra capsular tonsillectomy. See how large is the tonsil. I'm just taking the first incision on the anterior pillar of the tonsil to get into the correct plane. The wand is at the setting of 7 for ablation and 3 for coagulation. So that's the correct plane. Can you see this? So it's important to get into the correct plane and the first go. That's the correct plane. Now we'll hold the tonsil with the lux forceps and pull it out. Now these are the connective tissue fibers between the muscles of the tonsil and the lymphoid tissue of the tonsil. So I'm now facing the wand towards the tonsil and only dividing these connective tissue fibers so that I remain away from the muscles as far as possible. So in an extra capsular tonsillectomy, it will not be possible to 100% avoid the muscles because the child is also 11. But as far as possible, we'll try to remain only in this plane and not into the muscles. Alright? Whatever small vessels we see will coagulate. Now see, that's the correct plane. We are only dividing the connective tissue fibers. Large tonsil, so obviously we expect some large vessels also inside these fibers. There will be some large vessels. So we have to coagulate those vessels if we see them and very gently only separate the fibers from the lymphoid tissue. Now I can see a small vessel, so I have coagulated this. Now, can you see I have already reached the lower pole. That's the lower pole. Right? The tonsillar artery is going to be somewhere here inside. Right? That's the lower pole. Tonsillar artery is going to enter here. So what I'll do here, I'll now turn a little intracapsular only to avoid the main trunk of the tonsillar artery. So this is the connective tissue, this is the lymphoid tissue. So I am getting inside the lymphoid tissue. This I call hybrid tonsillectomy. And you see one of the branches has already shown up, but I do not want the main tonsillar artery to open up. I have turned a little intracapsular. Obviously, I am not going to leave behind any active lymphoid tissue. So there is no question of any recurrence. But as I said, the main tonsillar artery will be somewhere here. I do not want to open up the main tonsillar artery trunk. So that can give rise to significant bleeding in the post-operative period, even after 7 to 10 days. So I'll leave a small dressing over the main trunk of the tonsillar artery. All right. Without leaving any significant lymphoid tissue, we still have to make sure that there is no chance of a significant post-operative bleeding. That's the small dressing. You can see the brown dressing on the lower pole. All right. Now let's have a look at the fossa. You see, there is no exposure of the muscle in this area. There is a very little exposure of the muscle here, and maybe a small bit here. But this is the lower pole. The lower pole was not here. This is the lingual tonsil. The lower pole was so high, right? This is the mistake people do. They do not realize that the lower pole, they believe the lower pole will be there. This is the lingual tonsil. This was the lower pole. And I have left a small dressing. I have not opened up the main tonsillar artery at all. The chances of bleeding will be absolutely minimal. Minimal coagulation will ensure that the bleeding is least and pain will also be least. Thank you for watching.